Hello and welcome dear learners to the NPTEL course on Nutritional Epidemiology, A Way Towards a Healthy Life. In the Module 2 of Study Designs and Epidemiological Methods, for the Chapter 18, we will be studying about outcome assessment in nutrition studies. So what is the importance of outcome and the assessment to be done for this? The types of outcomes in nutritional epidemiology, the outcome classification, measurement methods for the outcome misclassification, sensitivity, specificity and predictive value, timing of outcome assessment across study designs, the applications of the outcome assessment in public health nutrition, challenges in outcome assessment, the quality control in outcome measurement. Also, additionally, case discussion will be taken ahead. So as you all know, in the outcome assessment, which is very important in the nutrition research, an outcome is a measurable health state. It is an event or a change in a patient or a population that results from an exposure. It can be like a habitual diet or an intervention like a dietary supplement. So an outcome assessment is the process which is rigorously observing or measuring these endpoints. So these endpoints are very important. The outcome assessment refers to the measurement or evaluation of changes that occur as a result of nutritional exposure, intervention or dietary pattern. So you can say outcome assessment is very important to see this changes actually. This measurement, this evaluation which comes from the changes is very important. It answers what effect did the diet or the exposure have. So why it matters and what is the importance of outcome assessment? It determines the validity of the study findings. It guides the policy and intervention. It links with the diet to the health outcome. So outcome is something very important. So what are the types of outcome in nutritional epidemiology and how does it really comes us to see as an importance? So if you take the clinical outcomes, which are very important for any healthcare institutions and healthcare provider, the disease incident mortality rate, like cardiovascular disease, like for example heart attack, stroke, MI and all those, cancer types and different types, or even type 2 diabetes. So clinical outcomes are something which has an indicator towards a disease incidence and a mortality rates. Anthropometric outcomes, particularly for nutritional part and in studies of nutrition, of malnutrition or obesity, where the body measurements like height, weight, BMI, body mass index, the body fat percentage and composition, which is very important to be seen as an outcome. Weight circumference, skin fold thickness, lean muscle mass. So if you see the anthropometric measurement which are done are being stated to give us the anthropometric outcomes. Biochemical biomarkers outcomes, which have been seen as a very prime importance nowadays to be seen as a biological indicators like blood lipids, okay, vitamins, minerals. Now for example blood cholesterol, LDL, HDL, triglycerides, serum, iron, ferritin, inflammatory markers, example CRP, okay, HbA1c, and you can understand through these biological indicators what are these outcomes being stated for this. Functional outcomes, as if like a physical fitness, strength, example grip strength, walking speed, running and all those. So it's a function and performance for the physical and cognitive status of your mind and your physique, for the muscles and the power. Cognitive function, example memory, attention, immune system function towards the prevention of disease, muscle performance in activity. Then comes dietary outcomes. So dietary habits and intake like food, nutrients, patterns and supplements. So you can understand fruits and vegetable consumption frequency, nutritional intake level, macronutrients, micronutrients, adherence to dietary pattern, for example Mediterranean diet versus a DASH diet, supplement uses, changes actually which are being taken as a single or in a combination like calcium with vitamin B12 or single vitamin B12 as a supplement. Patient reported outcomes, where a patient may come up as a subjective to give you about the health disease condition, quality of life, symptoms, satisfaction. So you may have health related quality of life, HRQL, perceived health status, symptoms like fatigue, pain, gastrointestinal discomfort, patient satisfaction with diet or the treatment. So it may be derived as a patient reported outcomes versus to the different types of outcome which are being stated over here. Then comes the classification, like how it is being coming as an outcome to you. So by study priority, you may say as a primary outcome, or you may say secondary outcome based on the additional supportive endpoints which are being listed, where you can come up with a study which is being seen as a secondary outcomes to a primary outcome. By measurement time, you may say a continuous like a weight and increase or decrease, categorical with obese, non-obese, binary, you may say disease present, absent, and so you can say the types according to the measurement. Types according to the timing, like short-term outcomes, long-term outcomes. For example, short-term outcomes particularly for a near future, you are planning for a study, or a measurement which is followed by a period actually lasting for an effects actually which may followed for years. Okay, by clinical you may say hard outcomes, so might be proving towards giving you some sort of morbidity, mortality, it might be related even to more deceased. So clinical are more understanding towards a hard outcome. Surrogate outcome. A surrogate outcome is a biomarker indicated to substitute for a clinical endpoints. You may be using it sometimes like using high blood pressure as a surrogate for stroke risk. Okay, very important. Or using high blood sugar as a surrogate for hyperglycemia or ketoacidosis. Or the final one is by source of measurement, objective outcomes versus subjective outcome. Subjective no doubt being seen really seeing as an very personal reporting coming from the patient, pain score, quality of life. Objective outcomes which might be coming as an indicators from pointing towards a level, might be a cholesterol level, blood glucose level. So an objective outcomes which are coming from lab, measured independently on the patient's feeling. You may see the measurement, clinical assessment, reviewing electronic health record, EHR, physician's diagnose and hospital discharge summaries. Very productively way of understanding the outcome. Anthropometric measurements in nutritional studies using calibrated like a stadiometers for height, weight, precise digital scales, DEXA scans for body compositions. Laboratory assessment utilizing standardized assays to analyze blood, urine, saliva for specific biomarkers actually. Questionnaires and surveys employing validated tools like food frequency questionnaires, which is very important to understand the outcome of the interventions that has been done, and a health related quality of life survey like the SF36. Surveillance and registry data, pulling data from national cancer registries or death certificates, database from long-term population tracking, and which can be seen as something a very important way to derive outcomes which are meant towards improving the health conditions, which are being seen as very important. Misclassification of outcomes. Sometimes you may have a misclassification. Non-differential misclassification. True outcome versus outcome measured with error. Non-differential misclassification occurs when errors happen equally across all the study groups. So errors are being seen in both the groups. This usually blurs the results and pushes the finding towards a null, making it look like there is no association, and you may come up also as a effect as an bias towards the null, and sometimes you may have a sort of a confusion. Differential misclassification. So differential misclassification occurs when errors are more common in one group rather than other. So one group is having more error, other group is not having the error to that extent. This is dangerous because it can falsely create a hide and association. Okay, commonly skewing the study's conclusion, which is sometimes being seen as giving a major deterrent, a major flaws. So results might be biased away from the expected, like you may say unpredictable, so towards the null. and this is being seen as a misclassification. Both of these are very important when you are taking ahead the study. You need to understand this. Sensitivity, specificity and predictive value. If you try to understand the sensitivity, it is the true positive rate, the ability of the test to correlate, identify those with the disease, and so you may say sensitivity. Then the specificity, true negative rate, the ability of the test to correctly identify those without the disease. And when you talk about this, the test results are being indicated towards a test positive or test negative. And positive predictivity. So the value is PPV, where the test is positive. What is probability the person actually has the disease, and it depends on heavily on the how common the disease is in the population, you may say, and the indicators can be coming with the formula, that is TP divided by TP plus FP multiplied by 100%. Okay. For example, if you are taking with the different sets of population, you may have to understand with a sample group of a disease condition versus you have to take about the results. In case of negative predictive value NPV, the probability that has a negative result is true. For example, if the person truly does not have the disease, so NPV is equal to Tn divided by Tn plus Fn multiplied by 100. So how to interpret this? High sensitivity coming as a good, where a high specificity good at ruling in the disease condition, and high PPV, that is positive predictive value, which is a positive result in likely to true, more likely in high prevalence, and high NPV, that is a negative predictive value, which is being result to likely to true, more likely in low prevalence. So PPP increases as disease prevalence increases and NPV increases as disease prevalence decreases. So you may understand the difference between this. Timing of outcome assessment, latency periods, the time lag of the disease where you can come, and a latency period is the time elapsed between the initial exposure starting a specific diet and a clinical manifestation of the disease. So you may talk about nutritional disease, or which may be associated with some set of a very chronic disease condition which may be taken for a longer period of time. And the examples might be like dietary exposure with a biological changes, subclinical disease, clinical disease, and a hard outcome which may relate, and it may take even a long latency, as if like from 5 years, 10 years to 30 years. Follow-up frequency, capturing the right signal, transient changes, acute. For example, measuring post prandial after meal blood glucose, or sometimes you may see morning you may have a spike, or it may come after 30 minutes or 1 hour after your food. A continuous glucose monitors, CGMs, okay, or permanent or slow evolving changes, that is chronic. So bone marrow you usually test actually for BMD, and bone turnover is slow process. Measuring the BMD weekly would show no change. Researchers typically wait for 6 months to 12 months and between assessment to detect a statistically significant trend for this. It's a very guiding principle for frequency of measurement to speed up the changes that the outcome has to be. Critical windows of assessment in utero and infancy. Assessing the outcome of mother's folic acid intake must happen changes in the birth, happens the birth of a child actually. If you wait until the child is 5 years old, you may miss the window where the exposure has its effect. Normal spine, spina bifida and anencephaly. So you may see preconception, pregnancy, birth, infancy, childhood, adolescent, adult and elderly. So this is a critical window which occurs before the birth, and outcome assessment should be done early to prevent it. Then comes aging, being seen as an example over here, assessing the protein intake for muscle preservation. Whether it is sarcopenia requires long-term follow-up in elderly population rather than a short-term burst in adults. So you may say muscle mass and strength change slowly over the period of time. Outcome assessment across study designs. So there are features, that is timing of outcome, direction best for primary error, risk and outcome metrics. So in a cross-sectional studies, the timing outcome is same time as diet. snapshot in as a direction, generating hypothesis best for, and the reserve causation and the prevalence as an outcome metric. Case control, you may say about assessed first, start, retrospectively it is being seen. It is being seen in rare disease condition, recall bias is there, and odds ratio as an outcome metric. For cohort, assessed in the future, prospective forwards actually as in direction, common disease as a long-term disease condition, it is best for use, and loss to follow-up is the primary risk, and incidence and relative risk is being seen as an outcome metric. In RCT particularly, as being stated previously also, assessed in the future, it is more towards prospective forwards and proving cause and effect, and non-compliance as a primary risk if you are not adhering to it, and it is being seen as outcome metrics in efficacy and treatment effects. Application of outcome assessment in public health intervention. You may see outcome assessment in public health intervention is very important. Program evaluation and impact assessment very importantly. Monitoring population nutrition status, policy development and decision making, identifying the risk factors and determination, evaluating interventions and effectiveness, particularly for it is helping in scaling effective interventions and discontinue ineffective ones. Cost effectiveness and resource allocation, it maximizes the impact with the available resources. Tracking process and can be seen as something which is giving you a progress, and it drives towards the global actions on nutrition. Improving program design and implementation is being seen as sometimes as a very important application which is creating towards a continuous cycle of quality improvement. Also, equity and targeting vulnerable population being seen to ensure that no one is left behind, and there is always a sort of an rural population, urban, women, children, all are included. Research and evidence generation is being seen as one very important application which builds the evidence needed for better nutrition decisions. Challenges in outcomes, measurement errors are always there. Misclassification bias cannot be seen as to be avoided. Recall bias, where you can say sometimes you may not be able to understand what are the behaviors, and even you cannot even able to guess accurately for these recalls. Lack of standardization, latency period issues, use of surrogate outcomes actually being seen as a substitute, loss to follow up actually, which is very important in migrants and all those people. Confounding factors where physical activity affects weight, making it hard to isolate the effect of the diet alone as an example can be seen as a confounding factor. Cultural and social influences which makes a major challenge actually, and resource constraints where money, funds, infrastructure, equipment plays very important role. Instrument validity and reliability issues might be seen to be coming as a poor validity with FFQ misses the local foods and underestimates the true intake as an example. Ethical and practical constraints which are coming as something which we may not see as an outcome but cannot be measured due to ethical concerns, and it is practically very important to understand the feasibility of this part, and this comes as in challenges in outcome assessment. Quality control in outcome assessment measurement is very important. Standard operating procedure SOPs which are being seen as a detailed step-by-step instructions for every single measurement, and very important and very tension regulated standardized procedure which is very important. So SOPs are being seen as very important. Training and certification, so rigorous training and certification exams very important before any data collection begins, where your competency is very important. Blinding, that is masking inter-rater reliability and intra-rater reliability. Blinding, that is masking outcome assessor does not know participants group assignments. Also, quality control for equipment calibration and the maintenance which is being seen as instrument accuracy. Independent adjudication, where objective verification is very important to vote to be seen as a blind expert panel review which will give you some of the observations which are being needed to correct. Finally, validation and auditing and monitoring, which gives a meticulous and a quality control which ensures towards an accurate outcome measurement and protecting the data integrity. Some important global case studies. PREDIMT study from Spain actually, which was an a Mediterranean diet and cardiovascular risk association. The objective of the study was to assess whether a Mediterranean diet reduces cardiovascular disease or not. The outcome of the study was that the primary major reasons was being seen as the cardiovascular events, heart attack, stroke, cardiovascular death, and heart clinical outcomes are being seen as secondary outcome like blood pressure, lipid, diabetes incidence, surrogate outcomes. So the measurement was done on clinical diagnosis, medical records, lab biomarkers, and a follow-up after 5 years. But the key insights demonstrated a Mediterranean diet significantly reduces a real cardiovascular event and not just the biomarkers as being seen. So it shows the importance of long-term outcomes to be stated to take the Mediterranean diet. So Mediterranean diets and its association with cardiovascular disease is pointed in the predetermined study. Nurses Healthy Study of USA, Diet, Lifestyle and Chronic Disease. This is a very important study which is being taken for 10 years of a period starting from a baseline, follow-up and 20 years. The objective was that to study a long-term effect of diet and the lifestyle on the chronic diseases in women, particularly nurses. The outcome was breast cancer, cardiovascular disease, type 2 diabetes, mortality, clinical plus self-reported, which is very important to overcome the biases. Measurement methods was FFQs, actually, that is a food frequency questionnaires, personal questionnaires, medical record validation, repeated follow-ups over the decades. The highlights were that it challenges of recall bias and self-reported outcome, emphasizes that there is a need of repeated outcome measurement for over long-term period to see that is there an association of diet, lifestyle and chronic disease. Then comes the DASH diets of USA, where the dietary appropriateness to stop the hypertension. So to evaluate the effects of diet on blood pressure, this study was done, and the primary outcome was blood pressure, systolic and diastolic continuous outcome. Secondary outcome was cholesterol, weight and metabolic marker surrogate outcomes. Measurement methods were standardized blood pressure measurement, lab test and control feeding phases. The key insights actually which comes are being shown that dietary change can quickly improve the measurable outcomes. So diet has a correlation with blood pressure. Example of using surrogate outcomes to predict the long-term disease risk can be seen as very important. So this is a DASH trial study. Then come Indian studies of midday meal scheme, which is very popular, which is being seen as an intervention in the school nutrition program, where the objective was to prevent child nutrition and increase school attendance, which has remarkably shown as an outcome assessment as anthropometric outcome, which was done with weight, height and BMI. Educational outcome, attendance, enrollment, retention, and biochemical outcome, in some studies hemoglobin. So the measurement methods was growth monitoring, school records, HB estimation and subsample studies. So what were the outcome? Example of multi-dimensional outcome which has come to state that there was an association with health and education, where nutrition played a major role. Data quality and implementation vary across the regions, and it was being seen that the midday meal scheme was being seen to be showing that there is a proportional way to understand that the child nutrition and increase in school attendance was being seen as fulfillment. Poshan Abhiyan, which is being seen as a national nutrition mission towards understanding the Poshan Abhiyan dashboard to come up as an to reduce the stunting, wasting and anemia among children, adolescents and women, which is being pointing towards the nutrition mission to come as an outcome assessment. Primary outcome stunting, wasting, anemia. Secondary outcome low birth weight, exclusive breastfeeding and dietary diversity. The measurement methods were anthropometry, height, weight, MUAC, actually mid upper arm circumference, HB testing, digital monitoring, ICDS and CAS and NFHS surveys. So the outcomes were being seen highlight like large scale population tracking enables real time monitoring. Challenges include data quality, standardization and follow-ups, but seen as a success actually, which is pointing towards an intervention which is very powerful through this program. NFHS, which is being seen as a very important indicators toward stunting, wasting, underweight and anemia. The objective of NFHS is to assess the health and nutrition indicators across the country. Outcome assessment is stunting, wasting, underweight, anemia prevalence, dietary indicators and we can find a diversity which is being coming to through the measurement methods, standardized anthropometry, biomarker testing, and structured questionnaire. The key insights, like it provides nationally representativeness, it is a comparable data, and it forms the base of policy planning and evaluation, which is being seen always when there is this NFHS as a survey which points out towards the major indications of providing as a representative of the information. Iron folic acid supplementation program, that is anemia control program, which is more towards before and after hemoglobin improvement, what are being seen as a reduction in terms of anemia among women and adolescents. So the primary outcome is hemoglobin level, secondary outcome is fatigue, physical work capacity, and cognitive performance. Measurement method was HB estimation and compliance monitoring towards the follow-up. What are the key insights? It relies on biochemical outcome challenges including compliance and irregular supply and loss to follow-up, where you may say that if there is an effectiveness to be seen for this type of program, there is compliance which needs to be improved, and even the outcomes of outcome that is relying on the biochemical outcomes. In summary to this chapter, where the outcome assessment in nutrition identifies to take a major role, it refers to a systematic measurement of health, behavioral and biological changes which is resulting from dietary exposures or intervention. Where if you talk about outcome assessment, it is including a wide range of outcomes such as clinical outcome, anthropometric outcome, biochemical, functional, and patient reported measures which are coming as an individual. So accurate outcome assessment is essential for establishing a valid association between diet and health outcomes. So if you have to take the outcome assessment, there should be a choice of outcome, timing of the measurement, and the methods that are being used greatly which are influencing the reliability, the interpretation of the results. Also, if you try to understand that evaluating the intervention, guiding policy decisions and improving public health programs are being seen as one among the major successes which comes from outcome assessment. Overall, robust outcome assessment ensures that nutrition research translates into evidence-based practices. It is also towards a better population health. So where we find that this is something which is coming towards helping us to understand how outcome assessment nutrition plays a major role. So with this we come and end to this chapter, and you can use these references which are pointing towards understanding more in detail about this. Thank you very much.